Good morning, everybody. We are pleased that the room is so full. My name is Piotr Myśliwiec. I work in the Medical University of Białystok, Northeast Poland, and I'm honored to co-chair the session with Professor Nasser Sakran from the Holy Family Hospital, Nazareth, Israel.
Okay, thank you again. We start today, but we have some changes, you know. So I am chief of department, and I am the past president of the Israeli Society of Metabolic and Bariatric Surgery. And I am a full professor in the Bar Ilan University, Israel. And we can start.
Before we start, I will encourage everybody to take your phone for a moment. I hope you all have the app of the Congress, because this is the way we'll ask questions during this session. So if you go to your app and you open the session, you'll be able to find the field interactive features on top. If you go to these features, in the bottom, you'll have the line with which you can contribute your questions. So please don't hesitate to ask your questions during the presentations, and we'll have 7 minutes for every presentation, and then 2 minutes for the discussion. Due to the delay of the first presenter, we'll start with the second lecture, and I am honored to ask to the podium Kathleen Kam from the Netherlands, who will give us a talk about short-term pulmonary outcomes after metabolic bariatric surgery, a prospective cohort study.
Thank you for the introduction. Can everybody understand me? Yes? No. I'm Kathleen, and I'm going to present to you the first results of the IMPROVE PF study, the impact of bariatric metabolic surgery on pulmonary function. I have no disclosures. I will first start with the impact of obesity on respiratory health, as this forms the basis of our current study. Obesity has a negative influence on the respiratory health because it has two main mechanisms in which it contributes negatively. First, we have the mechanical effects of adipose tissue, which limits the lung compliance. And second, we have the inflammation of adipose tissue, which contributes to reactivity of the pulmonary airways. If we look at the impact of obesity on asthma and COPD, so pulmonary comorbidities, we also see some negative effects. First, we see more complaints in patients with asthma in combination with obesity or COPD in combination with obesity. Second, we see a worse response to medication, such as inhaled corticosteroids. We see more exacerbations and more hospitalizations. It is known that weight loss in people with obesity has a positive influence on these things, but the impact of metabolic bariatric research and this taking care of weight loss has not been investigated broadly. We see in current literature mostly retrospective design, short-term follow-up, and small cohorts. So in the current study, we are evaluating the effect of metabolic bariatric surgery on pulmonary function. And we are doing this in a prospective observational study in which we include all patients undergoing metabolic bariatric surgery, and we're excluding patients who are not able to perform the spirometry or are not able to follow the instructions. So the primary outcome is the 24-month follow-up on the spirometry. As you can see on the illustration down below, we see a normal inspiration and expiration, then followed by a full complete inspiration, followed by a complete forced expiration, and then you get two important parameters. The forced expiratory volume in 1 second is the first one, and then the forced vital capacity. And those two are the most important parameters we are investigating at the moment. Then we have several secondary outcomes. So we're looking at complaints, respiratory complaints with the clinical COPD questionnaire, and also comorbidities like asthma and COPD. We started the study in September 2025, and currently we have preoperatively almost 300 participants included. Because we started in September, we right now have the 3-month follow-up. which are 86 people. And down below we see the baseline characteristics of these 86. The type of surgery they underwent, their smoking status, and if they have comorbid asthma, COPD, or use medication. And of the 86 people, we have 74 people who had a valid pre- and post-operative measurement of spirometry, which are included in the current analysis. So first, we see a decrease in body mass index, which is as expected. And if we look at the first parameter, the forced vital capacity, as you see in the upper right picture, is the total air exhaled after maximum inspiration, and usually you get it at approximately 6 seconds, but sometimes it's longer. This is expressed in % predicted, in which 100% is the mean of the total population, and it is compared to people of the same height, the same age, and the same gender. So if you have a measurement below the 70%, this could be a sign of comorbid respiratory disease. So what we see if we compare the cohort of 74 people, we see an increase in the median preoperative measurements, and then it goes from 95% to approximately 102%. If we do the same for forced expiratory volume in 1 second, which is the forced expiration in the first second, as you can also see in the picture on the right, this also increases with a bit more of approximately 77%. So for our current study, we also thought it was important to look at the patients with asthma and COPD. We want to look if they also profit from obesity surgery and if their bad controlled COPD or asthma could be improved by the surgery. So what you see for the forced vital capacity, which is a bit lower in the asthma and COPD group due to airway limitation, and then in combination with COPD, in combination with obesity, we see it becomes lower. And if you compare the pre-operative with the post-operative, you see in the no asthma and COPD group an increase, which is comparable to the slides before. And in the asthma and COPD group, we do not see really any difference at the moment. We still have quite some small groups, so we hope at the end of the study that we have bigger groups which can have more clear results. So if we look at the forced expiratory volume in 1 second, which is also limited in people with asthma and COPD, and then in combination with obesity even more, we do see an increase. So this is comparable with a few slides before. They start lower, but they increase with approximately the same percentage as the healthy group. Then we have some additional respiratory results. We saw that the pulmonary function increases and the body mass index decreases. So the question arises if this is correlated to each other. Well, we can say that there is a weak correlation at the moment, but it's not statistically significant yet. Maybe in the future, when we have longer follow-up on bigger cohorts, it will be. Then we saw in the questionnaire, in the complaints, we saw a significant decrease in the complaints. We saw no exacerbations and hospitalizations in the first 3 months. And we saw in one patient that they lowered the respiratory medication at the pulmonologist. So concluding, we see early improvements already 3 months post-operation. We see a possible clinical relevance because we see a small reduction in one patient of the medication. We see less complaints. And we like to follow up for 2 years with also inclusions of 2 years. So we hope to get eventually a cohort of 1,200 participants. And after 1 year, we also are going to follow up on inflammatory markers such as C-reactive protein and leukocytes. This is the end of my presentation. Are there any questions?
Thank you very much. Thank you for your presentation. I would have one question. Did you assess polysomnography? So did you diagnose the obstructive sleep apnea in the patients?
Oh, we did look at sleep apnea, but pulmonary functions are not really influenced if people have sleep apnea. I did see in some people that they stopped, for example, the CPAP or the treatment of OSAS. But at the moment, we did not look at that specifically because it does not influence the pulmonary function.
How can you explain that there is no direct association between the obstructive sleep apnea and spirometry?
Well, I think it's mostly because it's during a laying down position. So when people are standing upright, they usually do not really have complaints. So it does not influence the normal dynamic volumes during the day. But in the night, you see the obstruction. So I think that's a solution. I did not investigate it broadly.
Thank you for a very nice presentation, and I'm looking forward to see the results. Just for the part of the medication, because for that you have to rely on others. So how do you get a grip on the who's reducing the medication or not? Or you provide guidelines for them, or just leave it as it is, daily practice, and see what happens?
Yeah, this is indeed quite subjective, because people get at a general practitioner or at a pulmonologist their medication subscribed. So we are trying to optimize that at the moment, but we are going to ask the participants also with the questionnaire if they have any differences in their medication use. So it is quite subjective, but,
no, but
I think
it's daily practice. So thank you.
Okay, thank you very much. We need to move. Thank you very much.
Yeah, thank you.
Okay, then the next speaker will be again from the Netherlands today. It will be the name Mabel Kwakkelstein. It's a talk about the age-stratified outcome of sleeve gastrectomy versus Roux-en-Y gastric bypass, a post-hoc analysis of the sleeve pass trial.
Perfect. Thank you for the invitation. My name is Mabel Kwakkelstein. I'm a PhD candidate from the Netherlands at Franciscus Hospital in Rotterdam. And I'm honored to present you today our findings on the age-stratified outcomes of sleeve gastrectomy versus Roux-en-Y gastric bypass. This is indeed a post-hoc analysis of the sleeve bypass trial. I have nothing to disclose. Well, as we know, Roux-en-Y gastric bypass and the sleeve gastrectomy are the dominant metabolic procedures worldwide. Both procedures have proven to be effective in the long term. Generally speaking, Roux-en-Y gastric bypass is associated with slightly more weight loss, while the sleeve gastrectomy is often favored for its preservation of anatomy and the flexibility it offers for future revision or conversion surgery. However, we often have a dilemma in the outpatient clinic, like which operation fits best for which patient, because the role of agent choosing a specific procedure remains insufficiently clear to us. Does for example, a 60-year-old patient benefit from the same patient, operation as a 25-year-old patient? And that was a question we aimed to answer. So our primary objective was to compare the long-term outcomes of the sleeve versus the bypass across different age groups. We did this by conducting a post-hoc analysis of the sleeve bypass trial. The sleeve bypass trial was a multi-center randomized controlled trial, which ran from 2012 to 2017 in Franciscus Hospital and Catharina Hospital. And the aim of that study was to compare the sleeve and the bypass in the long term. And what we did for this study, we stratified it into tertiles based on age. So we have age group 1, 80 to 39, age group 2, 40 to 49, and age group 3, 50 to 64. Our primary outcome was weight loss, expressed in excess BMI loss and total weight loss, and secondary outcomes involved improvement of obesity-related diseases, complications, and revision and conversion surgery. And all outcomes were analyzed according to the intention to treat. Here you see the flowchart of the original trial. And we, as you can see, a total of 620 patients were analyzed. And as you can see, the groups are well balanced between the age tertiles, and that made sure that we could compare them meaningful between the sleeve and the bypass. Well, we go to the results, and first we go to weight loss, which we analyze using a linear mixed model. And here you can see that in age group 1, so the patients under 40, we saw no significant difference between the sleeve or the bypass in weight loss up to the 5-year follow-up point. However, when we look at the age group 2 and the age group 3, we see that Roux-en-Y gastric bypass resulted in more weight loss. Regarding obesity-related diseases, Roux-en-Y gastric bypass was associated with superior dyslipidemia outcomes in age group 2 and age group 3, as you can see here. Improvement of hypertension, type 2 diabetes, OSAS, joint pain was comparable between the two groups. However, although the improvement of existing reflux was comparable, de novo GERD was significantly more frequent after sleeve gastrectomy, but it was across all age groups. There seemed no real influence of the age here. Well, these are a lot of numbers. These are lastly our complication results. I will pick out the most important one, but we looked at minor complications, major complications, reoperations, revision and conversion surgery. And what we see is that in age group 2, so the patients between 40 and 49 years old, minor complications were slightly more frequent after Roux-en-Y gastric bypass. But more interestingly, we saw a difference in the revision and conversion rates in age group 1. For patients under 40, so the younger patient, we saw more revision surgery or conversion surgery in the sleeve group. As you can see here, the percentages. And no procedure-related mortality was reported in this trial. So, now, to the best of our knowledge, this is one of the first analyses to compare outcomes between sleeve gastrectomy and Roux-en-Y gastric bypass across different age groups. And both procedures are effective in the long term, but the age, it seems that it influences the relative outcomes. For patients under 40, no difference in weight loss or improvement of obesity-related diseases was shown between sleeve gastrectomy and Roux-en-Y gastric bypass. However, a higher incidence of revision or conversion surgery was in the sleeve group. And for patients above 40, Roux-en-Y gastric bypass resulted in significantly more weight loss, but also leads to greater improvement of dyslipidemia compared to the sleeve group. But what are the actual clinical implications of this study? Well, based on our results, for patients under 40, we still have a preference for the sleeve gastrectomy if feasible. Because this study showed comparable weight loss, we have preservation of anatomy, and we have future flexibility. Especially for women in fertile age, this seems very important to us. However, for patients over 40, I think Roux-en-Y gastric bypass gets our preference also if feasible, because it results in superior weight loss and superior improvement of dyslipidemia. However, this post-hoc analysis shows valuable insights for shared decision-making in outpatient clinic. However, external validation is needed before the definite conclusions can be drawn. Well, thank you for your attention.
Thank you very much. We open the floor for discussion. I would like to ask you, how would you explain the lack of difference in the youngest group between the sleeve gastrectomy and Roux-en-Y gastric bypass?
You can explain it maybe on a metabolic level, that the sleeve gastrectomy is enough for like a boost for the metabolic system in the younger patients, so that the difference wouldn't be that big. What also can be the case, also what we discussed, and is also a little bit of a limitation, we see more conversions to Roux-en-Y gastric bypass in the youngest group. So it can be the case that when we analyzed a lot of them, or a few of them got also the Roux-en-Y gastric bypass, so that the difference, how do you call it? It's the intention to treat analysis. So it's a little bit difficult to see that it's clearly only the sleeve. But the problem is we didn't want to analyze it per protocol because we don't think it's the same when you get a sleeve and then you get a bypass versus only the bypass. So that's the reason why we did choose for the intention to treat analysis.
What were the reasons for conversion to Roux-en-Y?
I think it was mostly due to recurrent weight gain and a combination of GERD. That was the biggest group. So the combination of those.
Okay, thank you, Eve-Jan Boerma from the Netherlands. I have a question following up with the previous question. So you, in your conclusion, in patients below the age of 40, you actually see a conversional operation as a pro to offer somebody a sleeve. I might suggest that's actually a con, because doing additional surgery is actually potentially harming your patient. So might you not even consider offering a gastric bypass even in patients below 40 so you can avoid additional surgery?
Well, thank you for your question. I think revisional surgery isn't always needed after a sleeve. We also have in our outpatient clinic and in our clinic, we see also a lot of people, patients that are very satisfied with their sleeve. So not everyone needs a conversion. And it can be a harm. I mean, it's an extra operation, but it's very well doable. We do it a lot, and I think for especially younger patients, there is also a lot of benefits from only having the sleeve, especially for women in their fertile age when they wanted to have children and etc. So it's also a decision you make together with your patient.
Thank you.
Thank you very much, and we go to the next lecture. Now we ask Åsne Hildmo from Norway to tell us about chronic abdominal pain and glycemic variability 10 to 15 years after Roux-en-Y gastric bypass, a cross-sectional analysis.
Thank you for your inviting. I am a PhD student in Norway in Møre and Romsdal Hospital Trust, and I will tell you about my PhD project. This is my disclosures. Well, chronic abdominal pain is a very common symptom after Roux-en-Y gastric bypass. And it is associated with reduced quality of life. And also it's among the most common causes of post-operative consultation in the healthcare. It is a very heterogeneous group, multiple etiologies, and the causes ranges from potential life-threatening to maladaptive eating patterns. But in a subset of affected individuals, the underlying cause remains unknown. So over the past decade, Over the past decade, the understanding of gut hormones has expanded substantially. And we know that abdominal pain is among the most common adverse effects of GLP-1 receptor agonists. We also know that gut hormones plays a central role in dumping syndrome and in post-bariatric hypoglycemia. And the shift in gut hormones increases glycemic variability. So we question, is there a link between gut hormones, glycemic variability, and gastrointestinal symptoms, and then abdominal pain among them? Continuous glucose monitoring after Roux-en-Y gastric bypass shows increased glycemic variability and also high prevalence of postprandial, nocturnal, and asymptomatic hypoglycemia. So our objective was to explore whether chronic abdominal pain after Roux-en-Y gastric bypass is associated with increased glycemic variability, more frequent hypoglycemic events, and also increased symptoms suggestive of both dumping syndrome and post-bariatric hypoglycemia. The study design was it was a part of the bariatric surgery observation study, part 2. This is a 3-center study in Norway. and it is a cross-sectional study 10 to 15 years after Roux-en-Y gastric bypass. We looked into two groups, individuals with chronic abdominal pain and controls without pain. And the definition of chronic abdominal pain was to have at least weekly abdominal pain for at least 3 months. The participants underwent continuous glucose monitoring with the Freestyle Libre 3 for 14 days. And the monitoring was unblinded, and they had no restriction of living habits. The definition of, we had measures of glycemic status, variability, and hypoglycemia. And the definition of confirmed hypoglycemia was if they had one or more events of glucose under 3.0 for at least 15 minutes. And as a supplement, the participants completed a self-reported questionnaire, included dumping severity scale, which have symptoms of dumping syndrome, and also symptoms of post-bariatric hypoglycemia. And this also distinguishes between severity in this scale, and we defined clinical suspicion of dumping syndrome and of post-bariatric hypoglycemia if they had 3 or more symptoms of moderate to severe intensity. So the results, we included 142 participants, 75 with chronic abdominal pain and 67 without pain. And the median follow-up time after surgery was about 13 years. In the abdominal pain group, there were female predominance. They had lower socioeconomic status, and there were a higher frequency of abdominal surgery in this group. Here are the CGM results. The time in glucose ranges were almost similar, distributed between the groups. And confirmed hypoglycemia were observed in about 54 of the total population, and no differences between the groups. And the CGM metrics of glycemic variability were comparable between the groups. Almost all symptoms were significant reported, more commonly in the abdominal pain group, with the except of flushing, is here in blue. And clinical suspicion of post-bariatric hypoglycemia or clinical suspicion of dumping syndrome, was seen in 51% of the abdominal pain group, and the clinical suspicion of post-bariatric hypoglycemia was seen in 16% of the abdominal pain group, and only 5 in the controls. So the conclusion, we saw confirmed hypoglycemia was common long-term after Roux-en-Y gastric bypass. CGM data in individuals with chronic abdominal pain did not reveal increased glycemic variability or more frequent confirmed hypoglycemia events compared to controls. And the individuals with chronic abdominal pain reported a higher burden of gastrointestinal, autonomic, and neuroglycopenic symptoms compared to the controls. So we should consider dumping syndrome and or post-bariatric hypoglycemia in this patient group with abdominal pain after Roux-en-Y gastric bypass. Thank you.
Thank you really for a very outstanding, I think, lecture, and I hope to publish your data because it's very important for us. And if you have some questions, some comments. Okay.
Hi.
Possible way to explain
We distinguish between 3.9, glucose under 3.9 and 3.0. So we had the data for both groups. But you know, CGM is not a diagnostic method for diagnosing hypoglycemia yet. So, yeah.
Okay.
Yeah.
Sorry. Yeah. We had data on abdominal surgery in both groups, and of course, in the chronic abdominal pain group, there were more internal hernia and gallstone formation and etc. Yeah.
Okay, great. Thank you very much. We can move. Okay, the next speakers again from the Netherlands, Nadia Boutros, and she'll be to talk about the association between anxiety and depression symptoms with gastrointestinal complaints 5 years after metabolic bariatric surgery, a cross-sectional study.
Yes. Thank you for the introduction. Imagine that you are standing here. Most of us will feel this in our stomach. I'm Nadia Boutros. I'm a PhD candidate in Rijnstaat at Vitalis in a hospital in the Netherlands and the Wageningen University. And I'm a nutritional scientist. And today I will tell you a bit about the research that I've been doing on the multidisciplinary support of surrounding metabolic surgery. I have no disclosures. So anxiety and depression symptoms are common in people that are about to undergo metabolic bariatric surgery. It is estimated that 25% of people have anxiety symptoms and even 35% have depressive symptoms. And we see that after surgery, these levels decrease. So anxiety levels decrease to 17% and depression to 20%. However, on the longer term after surgery, so also some studies indicate that these levels will return to baseline levels. So I think it's still very important to investigate patients having these symptoms. Another important outcome after bariatric surgery are, of course, as known, gastrointestinal symptoms. It's estimated that 20 to even more than 50% of people experience these symptoms. And there are some indications that these two are linked, so that gastrointestinal symptoms and anxiety and depression symptoms are linked. This is, for example, seen in populations with IBS, IBD, or GERD, but also in general populations. However, what happens with these symptoms after bariatric surgery is unknown. So therefore, we studied this association 5 years after bariatric surgery, metabolic bariatric surgery. So this study was a cross-sectional study, and all people that were invited, had surgery in 2015 were invited. Almost more than 1,000 people were invited, and this was part of a larger study on quality of life. So people filled in a lot of questionnaires, and in this analysis, we looked at 2 questionnaires. This was the Hospital Anxiety and Depression Scale. And this gives us an indication if people have no, mild, or severe anxiety or depression symptoms. And we also used the gastrointestinal symptom rating scale. And this gives us a total score for GI complaints, but also domain scores, for example, for abdominal pain and for example, reflux. But we also looked, we used the cutoff to make 2 groups. So we looked if people had any symptom that was moderately severe to severe. And we put people in 2 groups if people had this, yes or no. So in this analysis, we included 220 people. 5 years after surgery, there were 50 years of age, averagely, mostly women, 80%, and most participants underwent Roux-en-Y gastric bypass surgery. And in our population, 28% had anxiety and depression symptoms. And 15% had mild symptoms, and 13% had severe symptoms. And people with anxiety and depression symptoms were slightly younger of age. They had a slightly higher BMI. They less often underwent primary Roux-en-Y gastric bypass. They more often had self-reported IBS or GERD. And concerning lifestyle, these people reported less hours of sleep per night and also less hours of physical activity per week. And if we look at GI complaints, we see that 42% of people, of participants, had moderately severe to severe GI complaints, of which 22% was moderately severe and 20% was severe. And if you then look at the scores, the GI complaint scores, we see these the total score on the y-axis and the categories below for anxiety and depression symptoms. We see that people with severe, mild and severe anxiety and depression symptoms had higher levels of total. The GI complaint score was higher. And this was significant, and this was also the case for the categories. So this was for the total score, but also for the score for abdominal pain, for reflux, and for constipation. But we did not find this for diarrhea and indigestion. And if we then look at the two groups for having moderately severe or GI complaints, or severe GI complaints or not, we see that people with mild anxiety and depression symptoms, they had, after adjusting, 75% higher risk of experiencing GI complaints. And you can see from the confidence interval that after adjusting, this association was just not significant anymore, after adjusting for BMI and sleep. But if we look at the category of people with severe anxiety and depression symptoms, we see that they had a more than 2.55-fold higher risk of experiencing GI complaints than people that have no anxiety or depression symptoms. So in this first exploration, we did see an association if we look at the groups that I just showed and also at the GI complaint scores. This is in line with literature, from other fields. There we see that bidirectional relationship between the gut and the brain is plausible, and this is mainly linked to the gut-brain microbiota axis. Some limitations should be noted. We did not have preoperative data on GI complaints and on anxiety and depression symptoms. We also, very importantly, did not have data on medication use. For example, it's of course known that psychotropic medication can influence GI functioning, but also antibiotics and proton pump inhibitors. We also, in this study, did not have data on behavioral or dietary factors. Like, one can imagine that to which extent the guidelines are followed could have an influence, but also fiber intake, for example. And also in this study, we did not distinct between anxiety or depression symptoms. We made it one category, but you could, of course, imagine that these could have different associations. Although depression and anxiety symptoms also often co-occur with each other. This was also the case in our study. So all people with depressive symptoms, almost everyone also had anxiety symptoms. So I think this analysis is interesting to follow up, to have further prospective cohort studies on this topic. And it's also good to keep this in mind, I think, during clinical consultations. So now I hope my gut-brain axis can relax again after the presentation, and I would like to thank you for your attention.
Thank you very much for this excellent study. How do you think did anxiety or depression drive gastrointestinal symptoms, or could it be the other way around? The gastrointestinal symptoms could provoke anxiety or depression?
Yeah, I think it can go both ways. Indeed, like when you get nervous, you already notice that your gut maybe feel a bit nervous. This morning, my breakfast, I did not feel like eating that much for the presentation. But of course, also the other way around is possible. Yes, yeah, true. Yeah.
And how do you explain higher prevalence of depression amongst young patients?
Actually, also in the general population, the symptom levels are quite common. But it's also, in literature, it's also known that people living with obesity could have a higher incidence of depressive symptoms or depression. That's known. But also in the general population, levels are quite high. At least in the Netherlands, it is. Yeah.
Does the prevalence of depression among obese subjects represent the population prevalence?
If you look at the depression as a mental, like in the DSM-5, the disorders, then it's different. But actually, I looked it up for for depression and anxiety symptoms. That's something else than really a diagnosis, of course. It's maybe not. If I look at the numbers reported, it's also in the general population quite high. But
Thank you very much.
Similar.
And we go to the next presentation by Karmil Azran from Israel. Long-term outcomes of metabolic bariatric surgery in adults with type 1 diabetes, a real-world cohort study. Is Karmil Azran in the room?
Yes, here.
Please come to the podium.
It's because of Chetan. No, not.
Okay. Hi, everyone. Thank you for coming. Today, I'm going to talk about my research in type 1 diabetes and the long-term effects for patients after bariatric surgery. These are my disclosures. So we know long-term effects of metabolic surgery for type 1 diabetes there's not a lot of data out there, and this is why we decided to research it. And type 1 diabetes is kind of mixed diabetes for obese patients. This is very distracting. There are people talking behind me. I'm trying to focus. It's hard to talk this way. And overall, the research that was published for type 1 diabetes showed benefits of metabolic surgery. So in our study, we actually checked a lot of different things, but because of time, I'm going to try to give you the main things. The first thing we looked at was the clinical metabolic outcomes. So we did look at BMI, A1C, LDL, systolic blood pressure, just to see what happened to these patients in the long term. Then we looked at how much insulin they used. So we looked at insulin purchases over time. The third thing we looked at was safety profile to see complications in these patients over time. And the last thing, we actually did a comparison between the sleeve gastrectomy and Roux-en-Y to see if there were any differences in these patients. So this was the retrospective study at the HMO I worked at, which is 2.8 million patients. And we looked at electronic medical records. And what we did try to find were patients that had at least 10 years follow-up. So we looked at them over time. And our study population were adults with type 1 diabetes with BMI over 30. And we compared two groups, those that had surgery compared to patients with obesity, BMI over 30 that did not have surgery. So these are inclusion and exclusion criteria. They needed to have at least 1 year of follow-up. So our study years were 2010 to 2022. And we wanted to see that we have at least enough data over time And like I said, we looked at ones that had 10 years of follow-up. So the study was actually divided to different time periods. You can see here. So over my presentation, you will see these time periods. T1 was 12 months before surgery, and then we looked at 6 months, 12 months, 24 months, 5 years, and 10 years. So to look at the first objective of the study, first of all, these are our patients. So we did have, and this is one of the limitations of the studies, we had about 60 patients in each group. And we did see that actually our intervention group, our surgical group, was a little bit sicker. They had diabetes for longer. And actually, some of their parameters ended up being a little bit worse, and maybe that would explain some of the results, but we did actually after account for it in the way we showed our results. So when we looked at BMI, you can see this is, I hope you can see this well, yeah? We looked at absolute BMI, so you can see that our surgery group was a little bit, had higher BMI, and so you can see that in the first period, there was a significant decrease. You can see that in the graphs too, while our control group was steady and maybe with time increased a little bit. So because we had these differences, what we looked at, we actually did ratios, and we looked at the differences of each group compared to itself. So obviously, as expected, the surgery group over time had a more significant decrease in BMI compared to the control group. But this is something we expect to have after surgery. And then we started to look at the metabolic factors. So when we looked at A1C again, you can see that there was a decrease. The control group was pretty steady, but the surgery group was pretty steady too. There was a decrease. When you look at the ratio, you can see that there is a decrease, a significant decrease, but this is diabetes type 1, so we don't expect resolution, right? They don't start producing insulin because of the surgery. But we do see a significant benefit in the A1C. When we looked at LDL, we did not see very significant results over time. You see that the groups are pretty comparable. So we didn't see that the surgery did a lot for their LDL. I will say that we did see that a lot of, that actually there was a significant decrease in the number of medications purchased in the surgery group compared to the control. So even though we don't see a significant decrease in their LDL, and maybe they were well managed even before, we do see that they used less medications. When we looked at blood pressure, again, you can see here the ratio that there was a significant decrease mainly in the first period after the surgery. But over time also, there was a decrease in the surgery group compared to the control. Also, like I said, medication utilization in the surgery group was decreased also for blood pressure medication. When we looked at insulin utilization, so we looked at purchases because you can't really see well in medical records the dose, but we saw a significant decrease in the surgery group for the number of, or the amount of insulin that they purchased after the surgery. So they needed less insulin because of the surgery. And then for our third objective, this is something we're still measuring. Actually, we saw, you can see here, we didn't see a significant difference between the groups. We couldn't see anything significant when it came to DKA and microvascular disease. So that was not significant. We did have a result. I didn't bring it here because we're still looking at it. We actually saw an increase in macrovascular events for the surgery group. So they had more stroke and more MIs. So we're looking at it. We think it might be because they were sicker to begin with and they had diabetes over time that was longer, but this is something we're still checking. And then for the last objective, we looked at the difference between sleeve and bypass. So most of our patients had sleeve gastrectomy, and the rest of their parameters were pretty equal. So when we looked at BMI, we saw actually over time pretty similar results. And A1C, we did see a significant or near significance when it came to Roux-en-Y. So there was a more significant decrease in A1C for Roux-en-Y patients compared to sleeve, especially for the first period. For LDL, again, we saw a significant decrease for Roux-en-Y patients in the third period. So this was in the first year. And again, also, like I said, medication utilization decreased. I'm finishing up. So, for blood pressure, we didn't see a significant difference. So overall, we can see that bariatric surgery is adjunctive for obesity and type 1 diabetes. And the main results, you can see that at 10 years, there was significance in BMI reduction, A1C, blood pressure, and insulin purchases. And for Roux-en-Y, we saw significance in LDL and near significance in A1C. Thank you.
We can have one question. Please go to the microphone.
Thank you for your presentation. What I understand is that you see that after bariatric surgery, their insulin purchases are less. However, compared to the non-surgical group, they already had a much higher BMI, and their BMI dropped. I couldn't tell if you corrected for the BMI, because it also could be that the surgery isn't the influence, but the BMI is, since the non-surgical patients had a much lower BMI. Did you correct for that?
So, like I said, because we had those differences in the groups, we look at ratios and not the absolute numbers, because we understood like the groups were not similar. So we do think that the insulin purchases decreased because of the BMI, right? Because insulin is related to BMI, and so so we did look at that. But I didn't actually bring all the results. We have like way more. It's hard to fit it in, but I can show you after if you would like.
All right, thank you.
Okay, this is the last question. Thank you.
Yes, very briefly. Congratulations, but your study shows the same as that the ARMS study showed in type 2 diabetes mellitus and metabolic bariatric surgery. That is, better glycemic control, no influence on survival or complications.
Thank you.
Okay, thank you very much. Okay, Chetan, it's your turn. Okay, it's the last presenter will be Professor Chetan Parmar from the UK, and for me it's very interesting talk. It will talk about long-term outcome of anastomosis gastric bypass, a systematic review and meta-analysis of 5 years and beyond.
Thank you very much. Thank you, Nasser. Thank you, Peter, for the kind invitation. And thank you all for being here in the morning. So I'm going to talk on long-term results after OAGB, mainly 5 years and beyond only, so nothing less than 5 years. I'm one of the bariatric surgeons in UK, and Anuja was actually she's my fellow, but she has her FRCS exam next week, so you can imagine she couldn't be here. She's studying hard for that. These are my disclosures, nothing related obviously to this talk, but the main thing I just need to admit is my majority of, say, 60 to 70% of my work is OAGB. So please look at that in that light. Why are we having this talk in the first place? As we know, the 9th IFSO Global Registry, OAGB now is the 3rd most common bariatric procedures performed in the world, both as a primary and as a secondary or a revisional bariatric procedure. And I think hence we need more and more information about the validity, sustainability, and safety and efficacy of this operation. 2019 was when IFSO recognized this procedure, and we all collected, including Nasser, who is in the panel, in Hamburg, and it was approved, and IFSO endorsed what we call to be implemented globally. And that was the first Delphi procedure. So it's a gradual process since then. Since then, because once it was IFSO endorsed, obviously we went ahead and did lots of systematic reviews and papers looking at it at total less than 35 BMI, more than 50 BMI, and found that it was safe and efficacious. We also looked at the revisional scenarios. We also looked at revision after sleeves. The other concern was about cancer at long run and things. So we looked at a systematic review, looking also at the cancer incidence after not just OAGB, but after any bariatric surgery as well. So these things went on, and then we were asked the question that, hold on, guys, this is all 2 years, 3 years, 6 months results. What about long term? And I think that's how in one of the conferences, the question started, and we ended up doing this study. So we thought, okay, well, let's look at this paper where we only look at 5 years and more. So that was the inclusion criteria, that the paper had to have only 5 years or more results. Anything less than 5 were excluded. We are pleased to say that it's already accepted now as in obesity surgery. So this is the meta-analysis. When we first started, we came Prisma chart, nearly 2,000 plus studies, and we started excluding and ultimately ended up having 32 studies which were eligible for this paper. So let's talk of results. 32 studies across 14 countries we were able to include in here. Of nearly 19,000 plus patients, 68% of the patients were female. Mean BMI for this paper was around 44. Mean age was around 40. 26 papers evaluated mainly as a primary, whereas 4 also with revisional and both. The mean follow-up, as you can see, was 6.7 years, and the longest follow-up in one of the papers was around 20 years. So 6.7 years, I think, is quite good enough, because if you look, there is nothing on this on a sleeve or even Roux-en-Y at 10-year plus paper. Weight loss outcomes, 5 years. So I have divided that into 5 years and more than 5 years, so that just it becomes easier to understand rather than putting all those things together. So at 5 years, 75% excess weight loss. More than 5 years, in nearly 10,000 patients, 77% weight loss. The debate always with OAGB is about limb length, that the more you bypass, the more you get weight loss, and hence we made it a subgroup to look at 200 and less than 200 as well. So BP limb of greater than 200 at 5 years was 76%, and greater than 5 years, 77%. And then we looked at separate cohort, less than 200, even then we found it was 74 and 76. So there was no significant difference. And therefore, I think it's safer to rather do less, because then you have issues with malnutrition as well. Then the other question comes is, if you bypass smaller length, do you then have a lot of weight regain in those cases? So this is what 11 studies reported, some mention of weight gain, poor weight loss. So again, to be honest, if you look, I think I would highlight that if you read the IFSO guidance, it clearly says either you have to write a suboptimal outcome or recurrent weight gain. So this paper's, one of the limitations is they didn't clearly define whether this was just a suboptimal outcome or recurrent weight gain, but we still, for the sake of this paper, have highlighted that here. So nearly 13,000 patients, and we found that, again, it was not really big issue, 4% overall. I would accept that, to be honest, for the safety part of it. Again, if you look at less than 200 and more than 200, yes, there was a bit of a difference, but like I say, the definitions were not clear in any of the paper. Bile reflux, lot of talked about. We didn't find that much of an issue. De novo bile reflux was around 4%. Interestingly, in subgroup analysis, more than, so the longer the BP limb, less was the bile reflux. We can't really explain the logistic, but we mainly assume that it gets more chance of your biliopancreatic juice to be absorbed, and hence the lesser reflux. Marginal ulcer, again, nearly 13,000 patients, 2% at 5 years, quite acceptable. Again, if you have marginal ulcers or reflux, what to do? It's a very straightforward conversion to Roux-en-Y. So we looked at that as well, how many patients were reported. 3% of the cohort were only reported. Again, they're kind of vague, but that's what it comes out of this heterogenic data. And those procedures was quite easy with no complications or mortality. Obesity-related diseases, type 2 diabetes, again, I won't go in detail, but yes, good 80% and 88% resolutions and improvement. Same with hypertension, 69 and 61. Obstructive sleep apnea, 93% improvement and 89% resolution. This is probably something I would like to highlight for everyone as well who are doing future studies or so. When we talk of papers, we only talk of weight loss and all those things. We don't really document quality of life, and which was probably highlighted here as well. Out of this 20,000 patients, we found that quality of life was actually only measured in around 300 patients. Yes, in the 300 patient, it was excellent, but I don't think that's the true representation. And the same comes with all studies you look around, whether it's Roux-en-Y or SADIS or sleeves. That's one of the biggest problem if you look at any studies. So to conclude, a limitation before conclusion. The main limitation, like I mentioned, there were only 3 randomized trials. Majority are either retrospective or prospective trials, and the data had a lot of heterogeneity. And when you pull it, that's what we tried to do and get the results a bit stronger. So to conclude, I think we do now, or we can now say that yes, long-term data of OAGB is available. It's safe and sustainable results at 5 years and even beyond, up to 10 years. So we saw the mean was 6.7 years. Good metabolic outcomes as well, and good persistent weight loss outcomes. I think the debate around BP limb length, probably we could put at rest, that stay between the safety zone of 150 to 200 centimeters. If you obviously want to revise or go further, then probably you should measure your full total small bowel length. Reflux and marginal ulcers don't seem to be an issue. Conversions were easy, safe, and hardly needed. And cancer is not an issue, but again, I should admit that this paper was not focus on cancer, but we did a pre-systematic review looking at cancer after all bariatric surgery. We only reported 7 OAGB cancers total globally, and 3 were in pouch, 4 were actually in remnants, so we can't blame the operation for a cancer in the remnant. But I think what we need is, we need more randomized trial, and probably what we need is head-to-head comparison between Roux-en-Y's OAGB and sleeve in the randomized trial as well. With that, I would like to invite you for a British Obesity Society. That's my perfect timing. And for OAGB Summit in Obesity Days, which Nasser and we are all organizing in November. So if you want to know more about that, join us then. Thank you.
Hi. Congratulations for the paper. I have a mean question. Do you have data on the loss to follow-up of the studies that you analyzed? Because I have a problem with reflux. Seeing the plots of the hazard ratios, there are 2 or 3 clear outliers. One of those was the Omega trial, which has, if I remember well, 40% reflux at 4 years. So 1 to 10 difference between you. And that's the randomized trial with an excellent follow-up. My concern is that without the data on the loss of follow-up, a lot of complications might be missed. Not to the detriment to the message of a study, but just as a word of caution.
Thank you. So, well, thanks for warning. It was a mean question, so I'll prepare a mean answer.
Use the micro.
That's the best I could get. But even for Omega, if you look, the 5-year follow-up is 60% or so. So even in a randomized setting, you don't really have a 100% trial. So in a retrospective, I wouldn't expect. But even having said that, you still have at 5 years and beyond, there was still around 60-70%. And I think for a large cohort like this, probably I would accept that. And I could counter-argue the same as well, that sometimes complicated patients can come to you, but in the same way, patients with good results might never come to you as well. So, like I said, it was a mean answer. So how
all the patients that you have that suffered from marginal ulcers, they was converted to Roux-en-Y gastric bypass. How you can explain that?
No, so not necessarily. They said that all conversions where they were needed either for reflux or marginal ulcers were for Roux-en-Y, but not necessarily all marginal ulcers were reflected, because majority of marginal ulcers are still managed conservatively and successfully managed conservatively. So I think that sentence probably I should define better, that they didn't need any other fancy conversion. If they needed conversion, they were able to convert to Roux-en-Y's.
Also, I miss the mortality of this group.
Malnutrition is 1%, and anemia is 4%, but again, same, I was trying to be that 8 minutes, and mortality is less than 0.1%.
And what were the diagnostic criteria of marginal ulcer? Was it only the symptomatic patients that were scoped and diagnosed to have marginal ulcer, or was there any systematic endoscopy in the patients?
That's a very good question, but when you look at retrospective studies to get that definition, I think for marginal ulcers, we can say they all had pre-op endoscopy, but we can't say that they were all symptomatic patients had pre-op endoscopy because none of the papers specifically mention about that. And if you look at the IFSO position statement as well, they say that ideally all patients should have pre-op endoscopy. I probably can confess, and half the population here would say, or maybe 60% would say they don't do pre-op endoscopy even in symptomatic patients preoperatively. So I think that's one of those limitations for any bariatric procedure, just not OAGB. I think even for sleeves or Roux-en-Y as well.
Do you know the rate of perforated marginal ulcer?
Not in this study. That it's difficult to find in this study.
It's about 1.4.
Yeah, but for this we couldn't identify that.
Okay, thank you very much. And we can close our session.
All the presentations were of excellent quality, and all the studies you run are of very high and should be of very high quality, and big applause to everybody for your contribution. We'll ask all the presenters for the photo that we can have together, and thus we can close the session. Thank you very much for your contribution.